Good morning, all. My presentation is focused on this question of can lifestyle affect retinal health? And the study I'm going to present is on lifestyle related determinants of GCIPL thickness in South Indian adults. We all know that ganglion cell inner plexiform layer thinning can indicate optic neuropathies as well as neurological diseases, even if we forget retinal health. But what is unclear is what is the correct normative database of GCIPL thickness in Indian adults? What are its determinants in our population? And are there modifiable lifestyle related factors associated with GCL thinning in our normal population? So addressing these research gaps was the aim of this study. And the study was done in the hope that if we come across factors which are modifiable, it may be the first step in early detection and prevention of retinal neurodegeneration by it gives us an opportunity to implement appropriate lifestyle interventions on a large scale. So that would be an impactful aim of the study. After IEC approval, it was a cross-sectional hospital-based study conducted at a tertiary care hospital in central Kerala over a period of 18 months on by consecutive sampling of an adult population of 168 eyes were included, and all diseases, systemic, neurological, and ocular diseases that could affect retinal architecture, as well as factors which could affect OCT signal strength, were excluded from the study. Demographic data, systemic history of addictions, and digital screen time were recorded using a questionnaire. Thorough ophthalmic evaluation was done, including the anterior segment examination, IOP measurements, and a dilated fundus examination. GCIPL thickness was measured using the CALCI's SDOCT macular tube ganglion cell analysis algorithm. So in this study, the mean GCL IPL thickness was 79.49 plus or minus 6.37, with males having significantly thicker GCIPL compared to females. And we also found that aging causes a significant thinning in this neuronally active layer of the retina. In fact, GCIPL decreased by 0.151 microns per decade. Patients with diabetes and hypertension with no retinopathy or other clinical features were included in the study. And both diabetics and hypertensive patients had a significant thinning compared to those who didn't have diabetes and hypertension. In fact, diabetics had 2.72 times odds of having a thinner GCIPL. Digital screen time of more than 10 hours came up to be a very significant factor introducing GCIPL thinning. Smoking and alcohol, contrary to our expectation, did not actually come out to be a significant risk factor, whereas tea and coffee drinkers surprised us because more than 3 cups tea and coffee drinking was associated with a thinning of GCIPL layer. So this is just a composite real-life picture showing different demographics in a 60-year-old female with diabetes, hypertension, and these parameters, as compared to a 25-year-old male with no comorbidities. A 20 microns difference out of the 80 was actually demonstrable on OCT, which is quite significant. And this normative data obtained in our study is actually a little bit less compared to the other studies from the West and elsewhere in South India itself. And the differences may be due to geographic or ethnic diversity in some cases, whereas differences in inclusion criteria, because these other studies by Sundaram et al. And Elwan et al., both of them included diabetic retinopathy patients as well. So the inclusion criteria could have mattered there. And most of the existing evidences concurs with our observation that age, diabetes, and hypertension does cause significant GCIPL thinning. But we could not find any studies comparing GCIPL thinning and either digital screen time or addictions. So this is a cross-section study, but it provides very valuable research grounds for further exploration by identifying risk factors. Prospective community-based longitudinal studies for risk factor prediction are required in the relevant areas that are identified in this study. Digital screen time needs to be explored further in terms of the type of device, the blue filter, working distance, mechanisms of damage, etc. And to be frank, data was ambiguous regarding the beverage intake because patients did not remember whether they had tea or coffee, but most of them were having both tea and coffee. So studies focusing on exclusive cohorts of caffeine or tea addicts may provide further information. This is just some data that we got on a cross-section study. So in conclusion, the determinants of GCIPL thinning turned out to be age, female sex diabetes, hypertension at a digital screen time of more than 10 hours can significantly reduce normal GCIPL thickness from the 79.49 normative database in Indian eyes. Whereas, though tea and coffee drinking did provide some statistical significance, the clinical significance remains to be known through very longitudinal risk factor analysis studies. And what was surprising is that no GCIPL thinning was noted in the these factors which are known to produce actually neurodegeneration, especially in the context of glaucoma, sleep issues, snoring, etc., did not have any effect on the GCIPL. RNFL analysis was also done concurrently, and that too follows the same patterns by and large. So what this study adds is that diabetes strikes the ganglion cells first, even before it strikes the microvasculature and produces microvasculopathy. And computers and frequent SIPs are a wrong combo for the retina. So what the study actually adds to our understanding is that it's a reliable reference of normative data of South Indian population with specific reference to Kerala. Diabetic and hypertension and retinal neurodegeneration preceded fundus and OCT signs of retinal microvasculopathy. This is the first study in which digital screen time and caffeine have emerged as possible modifiable determinants of retinal neurodegeneration. And so it's recommended that this normative database should be borne in mind while interpreting GCIPL in Indian eyes, and it can be incorporated in diabetic retinopathy screening protocols. Prevention of lifestyle-related diseases and screen time less than 10 hours can promote retinal health, which is of contemporary relevance in the smart era, tech-based work culture and lifestyle, with all our youngsters glued to the screens all the time. These are the references. Thank you.
So, Dr. Lathika, sorry, that's a very nice out-of-the-box study, but I have got some questions. One is, in a qualitative research, it's very difficult actually. The quantitative researches are much easier than the qualitative research. You have done a good job. So, did you check the visual acuity, like, whether any lens changes were there, Locke's classification or something was used in this? And second is, like, you yourself said that in the age, there is as age advances, there is a thinning of the GCL, right? So you won't be comparing young with the adults. So you have got separate analysis for young and separate analysis for the adults also.
No,
was it done separately or you just compared as one? Because tea time in young, tea time in elderly population. So, age decade wise, have you checked?
Madam, regarding your first question, I excluded all refractive errors in the extremes of refractive. That's plus and minus 5 diopter sphere and plus 2 minus 2 the cylinders were excluded because extremes of refractive errors themselves can cause GCIPL thinning. So that confounder was excluded. And visual acuity of 6/6 with BCV of 6/6 was included in the study. And regarding your second question, we actually analyzed the age in these class intervals, less than 30 years to 71 to 80 years class intervals. But the addictions we analyzed as an entire group. We did not go into the particular, because actually this being a cross-sectional study, we were actually surprised by the results. So I think we need to design focus studies on these areas.
To be a little more better classified.
In this one, that was not really, we did not expect this finding.
Expect this, there's a surprise, right?
So what is the test-retest variability in the measurements? Like how many times will you test each patient?
Once. It's a cross-section study, so we saw the patient once only. It was not longitudinal.
No, in the same patient, if you test 2 times, will you get 2 different values? Like there is a test-retest variability,
yeah,
right?
but
what is
this
that?
Patient was only seen once. One patient was seen only once.
So you, okay, it is based on a single measurement for each patient.
Study, yes.
Comment. So in Alzheimer's, we have thinning of the GCIPL complex.
Yes.
And myself being a voracious coffee drinker, I will not agree with this. So, so what they say is, I have not checked. So what they say is, good heavy coffee drinkers, Alzheimer's is delayed and dementia is delayed. So in that correlation, we need to relook at the data of coffee drinking causing thinning of GC-IPL. I would not agree with that.
Surely, sir,
So-
this is controversial. I
Yeah.
told it in my limitations also.
Yeah, that's
But
what.
this is just, I mean, we have to look into it, that's all.
Okay.